Good morning, everyone. Happy Saturday, and welcome to Global Virtual Morning Report. Delighted to have you all here, and it's actually pretty exciting to see a small, compact group of people here today. As you may know, on Saturdays we like to celebrate one of the most joyful parts about VMR, which is that it really is a global community and a global community of people who are here to learn and reflect on medicine, but also things outside medicine, and to celebrate our different cultures and languages and much, much beyond that. So as a symbol of our Saturday slower vibe, I would love for you to actually, if you haven't had a chance to meet the CP Solvers team members, there's a whole crew, many of whom are around today, and maybe I can say hi to Vale and for her to reintroduce herself to the VMR crowd.
Thank you, Ravi. Yes, I am Vale. I'm calling from Lima, Peru. I'm a 6th-year medical student and really excited for discussing the case with you today. So I can pass the mic to Gabriel.
Hi, hello, welcome, CP Solvers. My name is Gabriel. As well as Vale, I come from Peru too. We study in the same university, and last week we are starting the 3rd year of medical academic. In Peru is the 6th year. The next year will be our last year, and we are very excited. We've been learning a lot through this pathway of the CP Solvers, and hope you too. Very excited for today's episode. I'll pass the mic to Marcela.
Hey everyone, so good to be here. My name is Marcela. I am a doctor from Brazil, and I am really excited to learn more from you all today.
Amazing. I just saw we have a late, not a late, but a later than start arrival with Dr. Ravi Singh. Hello, Ravi. How are you? Hi,
how are you?
Doing good.
Just came back from a basketball game, so a little out of breath, but
I don't know you play basketball.
A little bit.
Yeah, that's awesome.
Try and get some exercise in.
Oh,
yeah. Hopefully soccer season starts soon. So.
Oh, fingers crossed. There's nothing like that.
Yeah. So
Gabrielle and Vale are both moving us along. They're like, let's get down to business, y'all. What's the case? Does anyone have a case to present today? I can't help but also throw out a special shout out to Hans, Anna, Jasimran, and Abdulaziz for having your video on it. It's a delight. Thank you all. It's so great to see you. And if any of you are inclined to turn your video on, it makes my day to see you all. No pressure though, or maybe a little bit of pressure. Just kidding, just kidding. Does anyone have a case? We can dissect this apple together. Ooh, from the basketball court to the clinical reasoning pitch.
Yeah, I didn't want to leave you hanging too long, but I have a case with a sort of a global VMR sort of a spin.
All right.
I'll just have to give me about 2 minutes. Let me dig it up.
Oh, no worries at all. Take your time. Do you want to just give us the chief concern or something to play around with?
Apparently, I forgot the chief complaint.
Oh,
I think
okay.
it was.
No
yeah, let me just dig up the actual case.
Take your time. I'll come poke my friend Justin Run, whose voice I haven't heard in too long. How are you today?
Hello everyone. Yes, I'm good. So I was just looking through the like the people who are participants here, and I see some of the new faces. And I think I know one of I am PGY1 resident. Abdullah, if you can hear us, is this the first time you are joining?
Oh yeah, that's my first time joining, but
hello.
I've been listening to your podcast before.
Yeah, so I just wanted to, he's a PGY1. I am resident at St. E, Boston. So I met him once, so I was glad to see him here today. Yeah,
amazing, Abdullah. It's a pleasure to meet you. Tell us more about yourself, please.
Yeah, he's right. My name is Abdullah Mugrabi. I'm a PGY1 internal medicine at St. Elizabeth in Boston.
Right. Amazing. I'm not sure if your paths crossed with Adam Tapley, who is he was actually a sub-I that I had to work with, who I think just completed his residency there. So I'm not sure if you overlapped with him.
No, unfortunately, I have not. Also, a bit about myself. I'm interested in infectious disease in the
Right.
future.
Amazing. See how vigorously Vale and Marcella are nodding their heads. Both of them are infectious disease gurus. But the irony is Gabrielle loves leishmaniasis like no other. So I think all three of them are very similar. And where is home for you, Abdullah?
Jordan.
In Jordan. Oh my gosh, this is your Lebanese neighbor. I would speak in Arabic now, but I'm kind of embarrassed. I haven't spoken Arabic in so long. And where in Jordan are you from?
Amman, the capital city.
Yes, of course, of course. Well, I'm from a small town in Lebanon called Zahle. It's about an hour from, well, not an hour, like 30 minutes from Beirut. Welcome.
Oh, that's amazing. I have co-interns and co-residents who are from Lebanon also.
Really?
They are nice people.
Amazing. Well, I hope you can lure them to VMR, and Ravi and I will try to put on a show for you today, my friends, so you enjoy it as much as you can, and hopefully have our Lebanese friends join.
Thank you. I'm looking forward to that.
Of course. By the way, Jasimran, very pro move to just call out a video-less person. I love it. All righty, and we have some while Ravi's getting the case ready. I also see we have some VMR legends. Gitu is here, who's comments on Patreon. Oh my gosh. I just actually want to reflect on this briefly. I don't want to ruin our RLR case for you. RLR is what we talked about last week, where we had a case of hyperkalemia, and not to say more. But Gitu sent us an incredible article on the distinction between distal hyperkalemic renal tubular acidosis and renal tubular acidosis type 4, which is such a fascinating dissection of some very complicated things. So thank you so much for doing that. That was really kind of you.
All right, thank you. You're kind.
Yeah. All righty, Ravi, you ready to rock and roll?
Absolutely. Actually, this was great because there's not a lot of data points for this case. So using up some of the time to talk with people was absolutely spectacular.
Well, you know, I am Ravi the Rambler, so it's all
that's okay. So we have a 29-year-old male who is presenting with fever, cough, shortness of breath, and right pleuritic chest pain of 1 week duration. And I'll stop there.
That's a pretty significant constellation of things for a young person. I'll just mute for 30 seconds, see what thoughts come in the chat, and we'll try to get everybody's wisdom. Vale, please share your wisdom.
Yeah, it's actually just echoing one of the pearls that I remember you taught us about, like 4 triage or three triage questions when you admitted a patient with shortness of breath, and thinking about signs that could point you to the lungs or to the heart. And so, for example, for the heart, thinking about volume, like if the patient has edema, for example, and from the pulmonary perspective, if the patient has fever, as Gabriel mentioned, pneumonia is probably one of the most common presentations. But we should not ignore also the itis of the heart, like myocarditis or pericarditis, that could also present with fever.
Absolutely beautiful. I think when you're trying to figure out which of the two leading causes of shortness of breath, heart or lung, are at play, inflammatory lung diseases are way more common than inflammatory heart diseases. And that's because the lung has access to the most common source of inflammation, which is infection. The lungs are right there, open to the world to be infected. And I absolutely love that point. Abdulaziz is adding some specific infections. Abdulaziz, do you want to share your thoughts out loud?
According to the symptom of fever and pleuritic chest pain for 1 week, that it came related for infectious process like bacterial like pneumonia, viral infection like influenza or COVID. So the top of differential has become infectious process to exclude it firstly.
Wow, absolutely beautiful. Yeah, I think it's hard not to prioritize those infections and being very simple, pneumonia or influenza for sure. I'm curious what you all think about pleuritic chest pain. What does that do? Wait, what? Can you share more what you mean, Ravi?
Oh, about the I just love the fact that you really honed in on this pleuritic chest pain. So
Yeah.
that's really where I think Robbie wants you to focus, and that will actually prioritize what could be going on.
Yeah, I think there's something very unique about pleuritic chest pain, which it has tremendous localizing value. And honestly, the real hard part is that it's actually very hard to establish pleuritic chest pain with confidence. There are many patients who aren't sure how much worse their breathing is when they take a deep breath. And the way to be confident about it is to establish the biggest delta you can between chest pain without breathing versus chest pain when taking a deep breath. So if your patient says the pain goes from 0 to 10 when I take a deep breath in, that's probably pleuritic chest pain. But if the patient pain goes from a 5 to a 7 with taking a deep breath in, that's much, much, much harder to establish. So you often have a gradation of how pleuritic is the chest pain. And the more pleuritic it is, the more localizing value it has. Yeah, Gabrielle, I'm curious if you can expand on your thoughts.
Yeah, so for pleuritic chest pain, as you well explained, it could stand for a pleural irritation, and some triggers are, for example, pulmonary embolism that can cause ischemia that prolongs to the pleura. And in this kind of shift complaint could be a representation, for example, of endocarditis presented with pulmonary embolism, and that could also explain the fever, or maybe some kind of the shortness of breath. Also could be a pneumonia that is much classical in this chief complaint and can also irritate the pleura. And some other causes are, for example, malignancy and pleural effusion, for example.
Beautiful, absolutely beautiful. And Alex is adding some thoughts about maybe another location. Alex, do you want to share that thought out loud? Oh, I think you're muted, buddy. That's okay. I think Alex is doing us the kind gesture of having to literally move to another place to talk. Sorry. You just want to sit here and hang quietly, huh? But you get poked.
No worries. Yeah. So I was thinking about also the possibility of pericardial disease, given the pleurisy. Like you guys were saying, definitely also possibilities of a pneumonia or pleural pathology, but if you're irritating pericardium at the same time,
Cool.
Although it doesn't necessarily change the calculus just yet, but possibly could be involved.
That is such a fantastic thought. I have nothing to add to it. It's precise. And I think your commitment to trying to speak on VMR has maybe inspired Lorena to turn her video on. She did for a brief second. Then when I called her out on it, I think she turned it right off. Do you want to unmute and introduce yourself? I think this is the first time we met.
Yeah, sure. Why not? Hey, I'm Lorena. I'm studying in Graz in Austria. And yeah, I'm a fifth year medical student.
Amazing. I think you inspired Lorena, your colleague Leah, to share a comment in the chat. Leah, do you want to share that thought out loud?
Yeah, sure. Hi, I'm Leah. I'm also studying with Lorena in Graz. Yeah. And my thought was just that pleuritic chest pain can generally be caused by anything in contact with the pleura or in proximity. So I once read a case where it was actually hepatitis that caused pleuritic chest pain. I'm not sure whether it applies here, but just in general, when you have like differentials for pleuritic chest pain, it can be not just lung or pericarditis, but also like abdominal organs.
Leah, your thought is absolutely superb and spot on, and let's dive deeper into it. This is the value of, I think, having our collective wisdom here, because everybody touched on something. Literally, when we were having a conversation over the last 6 minutes, people have mentioned irritation of the chest wall. People mentioned the mediastinum and the abdomen. And let's break it down. So pleuritic chest pain has tremendous localizing value because it tells you that the pain only really emerges when the lungs move. But again, real life caveat. If the pain is only a little bit worse when the lung moves, you may not be in the right schema. So if somebody says it's going from 0 to 10 when the lung moves, you're probably in the right schema, but from 5 to 7, maybe not. So be careful. But then the question is, remember, the lungs are a 3-dimensional structure, and on the middle, they make contact with the mediastinum. And that's where Alex's thought of irritated pericardium can be the source of the pain when the lung goes boom right into the pericardium. And Leah just reminded us that actually the lungs also move downwards and hit the diaphragm and hit the abdomen. So liver or spleen problems can also cause pleuritic chest pain. But the most common source of contact is when it's made with the chest wall. And that is complicated because it can be what exists as part of the chest wall is the parietal pleura, and that's what can hurt. So pneumothorax, pulmonary embolism, inflammation of any kind can be a chest wall, or that you can actually have superficial disease. So if you break your rib or have a muscle strain, it'll also be pleuritic. How can we distinguish superficial chest wall pain from pleuritic chest wall pain? Is if the pleuritic chest pain is also palpably painful, it's much more likely to be in the ribs or the muscles. If the pleuritic chest pain is not affected at all by palpation, it's probably in the pleura itself, because you probably can't feel the pleura. So here the question is, which 3-dimensional structure does the patient, does the lung irritate? And the abdomen's definitely in play, so is the mediastinum, and so is the chest wall. And so how can you make further progress? I think you can make further progress by looking for the other 2 P's. Is the pain palpable? Then it's probably in the superficial chest wall. And is the pain positional? If there is positional pleuritic chest pain, we have to go hang out with Alex for the most morbid possibility of disease in the pericardium. So when you hear 1 P, pleuritic, stop and wonder about the other 2 P's. Is it palpable or positional? And that helps you make tremendous progress. In most instances, when a patient has accompanying shortness of breath, chest wall disease is unlikely. So practically here, the key question that you can ask on history is it positional to focus on the pericardium? But one other important caveat before I pass the mic to Ravi. We think about diseases in medicine based on probability, and that's what we're trying to get at with these questions. Is it positional? All these are probability-based assessments. But no matter what probability you're entertaining, you also have to entertain morbidity. And so when somebody says they have pleuritic chest pain, you have to think about these 4 diagnoses no matter what. And that's a PE, a pneumothorax, another mediastinal disease process, aortic dissection, and pericarditis. These are the 4 things that you have to rule out no matter what. And of course, there's some very important things you can't miss, like an empyema, but you can take a few hours to diagnose an empyema. You shouldn't take a few hours to diagnose any of these 4 things. Okay? Questions about that? Alrighty. Ravi, I'll hand the mic back to you to give us some more info.
Awesome. Those 2 schemas were brilliant. Definitely help in trying to understand or approach this process. So another layer of complexity to this case, he has a travel history in India 1 month back. While he was there were no sick contacts, was COVID negative, didn't have any unusual signs or symptoms, was relatively healthy until he came back here and then began to have these signs and symptoms. Past medical history, none, no surgical history, no allergies, no drugs. So pretty simple background. On physical exam, he had a temperature of 39. He was tachypnic, respiratory about 22, tachycardic to about 110. On examination, general looked ill. Chest, he had right-sided crackles over the lung, lower lobe, and also very tender over the right hypochondriac region. the rest of the exam was normal. His skin was normal, just a little diaphoretic. I'll go on to the labs, or would you like me to stop there?
Ravi, there's the exam is so helpful. Why don't we just take a moment to reflect on it? And I'm curious. I'll just pause for a minute. There's a lot of data in the background history and then in the foreground. So maybe we can just start to collect people's thoughts. So Jasimran, tell us what you're thinking.
So when Dr. Singh just gave us the history regarding the recent travel, so some of the risk factor that we should be considering in the history in this patient, in a young patient, would definitely be something which is not chronic. So pulmonary embolism or infection can present this way, and it is acute. And with recent travel history and tachycardia, both of these are high factors in modified Wheel score, which we used to take for the prediction of pulmonary embolism. And definitely when it says India, TB is in the back of my mind. It's because I have been studied my medical school in India, and TB can present in such a variety of varied symptoms. And this is one of the most common that it can present in an acute phase. So definitely I would get a TB test and a D-dimer to rule out at least these two causes.
Absolutely superb, my friend. Absolutely superb. I have nothing to add. And Vale is mentioning another specific feature that prompted some concern for TB. Vale, do you want to share that out loud?
Yeah, I think I heard that it was, yeah, Ravi, I heard the upper level sensations of TB because TB or mycobacteria love or thrive in oxygen. And I think maybe I think also Klebsiella localizes to usually the upper lobe. And maybe we will dig up also their risk factors if the patient, for example, has had an organ transplant with Aspergillus, but it should not be this acute. So I agree with Jasimran that TB came to mind definitely.
Beautiful, 100%. I love it. Abdulaziz is reminding us of another organ we should think about. Abdulaziz, do you want to share your thoughts? Oh, I think you're muted, my friend.
Yeah, can you hear me now? So
yes,
because the patient have right hypochondrial pain that to my mind is liver abscess from amoebic or bacterial abscess. So that's presented by right hypochondrial pain and lung disease. So why that differential for me?
yes, we still have to have one foot somewhere else. I think there's a lot of reasons to worry about TB, but I think worrying about the liver here is really, really important. Thank you. Jane, I think your question is superb. Do you want to unmute and ask it?
Yeah, sure. I think the pulmonary exam is definitely very telling, and it does kind of localize it more to pulmonary. But as we mentioned earlier, there are certain like PE or pericarditis that we might want to rule out. So I think the CV exam would be a good one to kind of make sure we don't miss anything.
Couldn't agree more. I couldn't agree more. Are you finishing up your third year, or have the years transitioned?
Oh, I'm so impressed that you remember. Yeah, I'm finishing up my third year. I just finished my surgery block actually. So yeah, feeling good about that.
That was the hardest block period in med school for me. So I'm glad that you're over that hump. Yeah, and then Robbie's updating us that thankfully the cardiac exam was completely normal. All right, y'all. A fun teaser question for you, for our infectious diseases gurus. How much, on the scale of mild, moderate, or extensive, how much exposure does one need to tuberculosis to actually get the disease? What do y'all think? Mild, moderate, or extensive? Jasimran's like, one bacteria is enough to get TB.
I attended a conference by a specialized, and they told me just single bacteria of tuberculosis is enough, Mycobacterium tuberculosis, to cause the disease. Single. Yeah. That depends upon the status of the person, whether to catch it or not.
Yes. Amazing. Other thoughts, folks? All right. So if you understand TB, you understand all of medicine. It is one of the most fascinating infections known to personkind. The incubation period of tuberculosis, usually from acquisition to infection, is about a month, as Hans is saying. And there's some very intriguing thing about mycobacteria. That includes Mycobacterium leprae or leprosy, and non-tuberculous mycobacteria and tuberculosis. You can infer how infectious an organism is based on the fact that when we as providers go into a room with somebody with TB, we're wearing N95 masks. So the infectivity of the organism certainly is something that prompts us to behave differently. However, it really does require exposure to somebody who is fairly infectious for a reasonable period of time. To even get that small amount of microbiological exposure, it takes a lot. Now, here's why. The replication time or the duplication time of Mycobacteria species tends to be very slow. That's why it takes forever to culture it. It takes up to 6 weeks to culture the organism. So even though you need not too much organism to get the infection, it does take a lot of work for that one organism to reproduce, to be coughed up towards you. So counterintuitively, tuberculosis and leprosy are not profoundly travel-associated diseases. The reason for that is most people who are, quote, traveling are staying in places for short periods of time that usually don't occur sufficiently to acquire mycobacterial infections. But that's when you have to step back and understand the cultural associations with travel. And if somebody is going to travel to India to visit India, the chances of tuberculosis are low. However, if somebody is from India going back home to visit India, the chances of TB are higher. Why? One, the cumulative exposure is probably higher. And two, the extent of the exposure with one's family is much, much, much higher than when a visitor is traveling and passing by. And you'll see this is fascinating, is a great reflection in the New England Journal of Medicine, how people who are returning back home as part of travel are much more vulnerable to infections than people who are visiting and making less contact with individuals. So here, I think that's a key question. The chat is sharing some tremendous pearls, including some from Franco. Franco, do you want to unmute and share your great wisdom?
Hi, everybody. Well, here in Peru, we see a lot of TB, and for the risk factor, sometimes we ask the patients, how often do you eat lunch together?
Yeah.
So if you eat lunch together, most of the weeks of the day, your risk factor is really stronger. Instead, if you're like someone who visits someone twice per week, it's not the strongest risk factor to getting the infection. And also, we take a lot of risk factor in acquiring TB in the immune status, mainly the malnutrition or something like an immunodeficiency. Something that can also be a really important risk factor in countries that don't have like a public transportation that is well ventilated can also become a risk factor for that.
Franco, that is absolutely amazing. Thank you for that premise. And I think Justin Brown is crystallizing it in 2 words. He just said it so well in the chat. He said, very good questions to get at. And here's the key variable, contact time. And I think that really captures well the crux of the variable. And by the way, that's not true for many travel-associated infections. Many travel-associated infections, the contact time can be so small. Tick-borne diseases, mosquito-borne diseases, waterborne diseases. You can just be in contact with a mosquito for 5 minutes and have malaria, or a tick for 5 minutes and have scrub typhus. So the contact time is really a relatively unique variable for TB, and is the one good thing about how infectious it is. All right, so I think most people now are saying, hey, this is a febrile pleuritic chest pain process with tenderness in the chest wall that we're probably prioritizing a pleural disease process, and pass the mic to Ravi to give us some more information.
Oh, the crowd is absolutely amazing. Some great thoughts there. This is exactly the train of thought I was pursuing when going through this case. So on to more data. So labs white count was 16,700, 81% PMNs, normal eosinophil count, AST 112, ALT 219, ALP 219, direct bilirubin 0.61, total bilirubin 1.0, and D-dimer 3.83. And the next aliquot is imaging. Should we just stop there for a few minutes if anybody wants to sort of go over the labs and have any ideas what's going on?
Rami, nobody was expecting some liver enzyme perturbations except my dear friend Abdulaziz, who's like, this is liver problem from the beginning. So Abdulaziz, will have to get your reflex response here. What do you think?
Yeah, this is a really amazing case. So the liver enzyme was very high, as ALT and ST high. It means that the liver is infected. So maybe it's liver abscess. We think sometimes atypical pneumonia can present like that. It affected your lung and your liver.
Yeah.
So like mycoplasma pneumonia and Legionella can do that like that. So maybe atypical pneumonia or process of liver disease like liver abscess, amoebic liver, hydatitis. So this is common.
100%. My dear friend Anna is nodding and supporting you. Anna, do you have any thoughts so far?
No, I'm just so like amazed of how much like knowledge they have, because I was just like pneumonia, and then I was like pulmonary embolism, and maybe like I've seen a couple of cases where people come after traveling and they had like a pulmonary embolism. But then when we did the chest CT, you saw kind of like the stroke, like the pulmonary, like stroke, and they had like a pneumonia over it. Yes. And they used to come for like fever and chest pain. And so it reminded me of that. But now the liver, it's like, I think Abdullah said is right.
Even though you said, no, I have nothing to add, you just made a brilliant point, which deserves a highlighter, which is we often think travel and we go immediately to infection, but travel associated pulmonary embolism, you have to think about it. I think that point should be bold and underlined. And then you're making an even more important point, in my opinion. Pulmonary infarction. So when people have chest pain from their pulmonary embolism, they probably have a pulmonary infarction. There's no other real reason for your chest to hurt when you have a PE. And so what is the rate of complication of infection of a pulmonary infarction? So you have an infarcted tissue that's lung, that's dead, dying. And the bad thing about dying lung is it's exposed to oxygen, right? And so there's a high rate of superinfection of pulmonary infarction. Don't tell Reza, the next case that I'm going to present to him on RLR is actually a case of both pulmonary infection and infarction. We just saw it last week here. So we really should think about that possibility here. And somebody who travels, who has risk for PE and is definitely infected. But I agree with you. I think Abdulaziz's framework of hepatitis changes things here. It's either a liver infection going up and irritating the pleura, or it's a liver plus lung syndrome. And I don't think we can tease that out. Our new friend from Jordan, Abdullah, has some great thoughts about the combo of those two. Abdullah, do you want to share your thoughts out loud?
Yeah, the fact that he has leukocytosis and fever points towards an infection, but he has cough pointing towards the lungs, and at the same time hypochondriac region tenderness and liver enzymes elevated pointing towards the liver. So could it be a source of infection far away from those, like infective endocarditis causing septic emboli to the lung and then also an abscess in the liver? The fact that there is no mirror on exam points against that, but I'm not really sure yet.
Superb. I love how you didn't use the murmur as a definitive argument against your hypothesis, but rather that subtle use of language, it argues against it. You can see how when somebody's a heart rate of 110, the chances of us picking up a murmur is very low. So I love that thought. My friend Motaz has some thoughts about a specific organism. Do you want to share your thought out loud?
Good evening. How are you, Ravi?
I'm good. How are you? Better now to see you.
Thank you very much for giving me such opportunity. But I am having only a suggestion from his young age, and he's exposed to travel history. He can be exposed to mycoplasma pneumoniae infection with maybe cold agglutinin can be causing such hepatic with lung. Maybe only a suggestion.
That is a beautiful thought. I think we all have think mycoplasma is benign, but it's not. It can cause people to be very sick. And so for the reasons you mentioned, I think it definitely deserves to be here. And my friend Leah has another thought to another organism. Leah, you want to share that organism out loud?
Yeah, I think it's a similar thought. Like chlamydia can also make atypical pneumonias and elevated liver enzyme when they affect the liver as well. I'm not sure about the illness script exactly, but maybe that's something to think
about. Leah, you're making up a great point, and I want to take this time to take a minute to clarify for those of us who think chlamydia and are like, wait, what, chlamydia in the lung? That doesn't make sense. And the reason that can be confusing is because there are different kinds of chlamydia. And the chlamydia that I think we diagnose most often is called chlamydia trachomatis, and that is an infectious, a sexually transmitted infection. But then there's two other chlamydia. There's Chlamydia pneumoniae, and then there's psittacosis or Chlamydia psittacoccus. And the latter two are very different. So Chlamydia pneumoniae is often a very mild bronchitis type infection that doesn't cause advanced disease. And that is a highly prevalent person-to-person infection. Psittacosis is associated, which is the infection that I think you're thinking of, causes liver, lung, and pretty severe symptoms. And most often the exposure is to birds, but it can be any avian product, and it actually can be rodents too, like rabbits and subtle exposures like that. So if you're a learner and you're wondering, hey, chlamydia plus lung, that doesn't make sense, it's because Leah is bringing up the idea that there are two other chlamydia that can cause pulmonary infections. Okay, so I think the tension is, to summarize, the liver enzymes have reminded us that there are some lung plus liver syndromes going both ways, lung to liver or liver to lung. But it may be simply that you have a disease process in the pleura irritating the chest wall and irritating the liver indirectly. So I think the key question is it liver plus lung or lung plus liver, or at the interface that divides the two? And I think imaging would, as Ravi suggested, would help tease out that distinction. All right.
Okay. I guess a good question, if we have a minute, what would you like to order at this point? There's different kind of images that we could do. And then I'll disclose the image that we actually got. Okay, very good. So X-ray was unremarkable. Good, very good. So then I guess CT was exactly what the team was thinking, because there was also elevated D-dimer of 3.83, and also like Anna had mentioned, the travel history. So could there have been a hypocoagulable disorder and a PE? So the CT chest showed bilateral streaky, peripherally based opacities in the lung, no evidence of PE, and a large hypodense lesion within the posterior right hepatic lobe. So this right hepatic lobe lesion, sometimes you do an image of the chest and you get a cut off some part of the liver and you incidentally find this sort of a feature. So that this happened in this case. And subsequently, the next image was a MRI, and I'll share that with you if let me just click the share screen. Oh, are you able to allow me to share screen? Okay. All right, here we go. So the MRI of the abdomen with contrast showed a 9.5 times 8.3 centimeter subcapsular unilocular right hepatic lobe abscess. And subsequently, a procedure was done, an ultrasound-guided drainage with aspiration of the thick, dark brown fluid with placement of a pigtail catheter. And I'll stop there if anybody has any ideas.
Oh, Abdulaziz, your wisdom is knows no bound, my friend. I'll mute for 30 seconds just to accumulate some thoughts in the chat, and we'll go from there, okay? Oh my God, I don't have to mute for 30 seconds. The thoughts just keep flowing. Vale, do you want to share the radio? There's some food items mentioned in the chat. Sauce, anchovy, chocolate. Yes, we in medicine are a little eccentric. Vale, do you want to share your thoughts?
Yeah, I remember I learned the differentiation, I think, from Franco. He presented a case of an amoebic abscess as well in the liver. And I remember from that thick borders, I think, and now I'm a little confused. No, I think thick borders will point out towards amoebic abscess, and the differential there will also be Echinococcus abscess, which will probably show septate rather than thick borders. And bacterial, I think it will have more thin borders rather than the thick, but you can correct me there if I'm wrong, because I think of those three possibilities: amoebas, bacteria, and then Echinococcus.
Yeah, I have no idea. I unfortunately don't know what the radiographic characteristics are like. And so I'd have to look it up unless somebody else knows. But yeah, I agree with your differential. I think is this either bacterial, amoebic, or Echinococcus. And Echinococcus is typically cystic and has some septation. So the radiology on that is superb. It looks like Franco is giving you the heads up. And maybe Franco, you can unmute and just tell us what you know about the radiology of this.
Oh, Vale, I have nothing to add to what Vale said. It was brilliant. something that can point out also to Echinococcus, it will be like sometimes when there is a rupture of the Echinococcus cyst, maybe it's in the lung, can release a salty flavor of the cough. That is also a perk for the Echinococcus. And we should be aware if there is a rupture of that, it will be like an anaphylactic shock picture. That's something that I can add.
I love that. I think that's superb. And you continue the food theme. We now have sauce, anchovy, chocolate, and salty sputum to try to understand the liver abscess. I love it. Okay. I think all trains are leading towards this being an amoebic liver abscess. And I think that to reflect on that, this is a great case for an amoebic liver abscess because it is the right patient population who gets an amoebic liver abscess. So the first thing is amoebiasis is a fascinating infection. It's found worldwide, even in the United States, and the intensity of the disease varies from asymptomatic disease to chronic fistula forming disease, to hyperacute necrotizing perforating infections, to metastatic infections. So the spectrum is very wide. And if anybody's going to have a metastatic infection, it tends to go to the liver from the GI tract. And curiously, the metastatic infection in the liver tends to be right hepatic lobe dominant and tends to occur in men for reasons I don't know and I don't think are understood. So when you say a young man has a right hepatic lobe disease process and has been exposed to entamoeba in India, that's a very good case. But we have to also step back and remember that this person traveled to India but has been outside India otherwise. And so this is where I'd love to share with you. Oops, sorry, I forgot to open it. Let me open it again. I think we have to be here's a systematic approach to the possibility of a liver abscess. And the key, I think, is to recognize, well, what bacteria specifically could it be? And I think Abdallah mentioned a really important one already. So the bacteria are, of course, Staph aureus. Strep milleri are very, very abscess forming, and the Klebsiella. So the hypermucovirulent Klebsiella strain is now prevalent everywhere, and we have to think about it in this case. And then if it's not bacteria, think of the 3 E's, the endemic mycoses. So could this be histo, blasto, Thalacromyces in India, or is it entamoeba or echinococcus? So I think bacteria or the 3 E's immediately. And within the bacteria, in a young, otherwise healthy person, the only bacteria that can cause devastation is Klebsiella hypermucoviscus. It's usually in patients who have diabetes, but more and more so in anybody. I'll pass the mic to Ravi, but before that, I'll share one final pearl, which is the white blood cell analysis here can be helpful. One very fun feature about amoebic liver abscesses is the amoeba tends to be cytolytic. And what that means is the amoeba eat the white blood cells in the actual aspirate. So you tend to have a low white blood cell count in the aspirate that you remove, that also has these very wonderful foodie descriptions like saucy anchovy paste. So a low white blood cell count is another helpful feature. All right, Ravi, I'll give the mic back to you to tell us what the answer was and what you learned from it.
Sure. Excellent thoughts. I really enjoy that the crowd is participating this much today. So the gram staining culture of the aspirate and blood cultures were negative. Echinococcus antibody was negative. Our serology for the E histolytica IgG returned positive. Hence, patient was diagnosed with entamoeba histolytica and was managed with metronidazole, and symptoms improved. And then a repeat CT of the abdomen showed interval decrease in the size of the abscess. So a few things. I had the same sort of perplexed thought. Why do amoebic liver abscesses happen most commonly in the men? And usually around the 4th and 5th decades of life, but it can be any age, as in the case of this patient. There are some risk factors such as alcoholism, malnutrition, and Franco had mentioned immunosuppression in the case of TB. That can apply here as well. This patient also had hepatic vein thrombosis. So for some reason, chronic anticoagulation wasn't necessary. So a few points with this case. Amoebic liver abscesses should be included in the differential diagnosis when encountering fever in the returning traveler. In the right clinical context, diagnosis is generally established by radiographic imaging and confirmed with serologic or antigenic testing. When you have a high clinical suspicion, a CT or MRI will help diagnose the complications of amoebic abscesses. And worldwide infection with E. histolytica is the second leading cause of death from parasitic infection. Amoebic liver abscess is the most common extraintestinal manifestation of amoebiasis. So prompt recognition, appropriate treatment of complications leads to improved outcomes. And some of the complications, like Frank had mentioned, rupture of the cyst can be very, very can have a very adverse outcome.
Ravi, I totally get what you mean by how this case has a global vibe to it. I really, I'm very grateful and appreciate you for bringing it to us. I think it's not a diagnosis we often see here in the US, and I think it's so telling. Thank you, and for the great pearls. It's hard not to shout out Abdulaziz, who was on the liver train from the very beginning. So thank you for that. But I'm also very grateful to have met Abdallah today for the first time, him joining VMR, and heard Leah's participation, Anna's participation. Also got to very briefly meet Lorena, who was also hanging out with us from Austria, and hear many other familiar voices. Also grateful to you, Alex, for the mid VMR room change, and to, of course, the CPS crew who make all of this possible. Hans and Gitu, thank you for your wisdom in the chat. And Jane, congrats on being done with your surgery rotation and moving on to 4th year. And Jasimran, I don't even know what to say. You're a pillar of VMR. It's great to have you here, and to everybody else who was hanging out and couldn't participate. We hope you're more comfortable doing it next time. The special list of shout outs is to the last minute teaching points person, Marcella, who was just coming in, minding her own business, but then jumped in to put in these incredible teaching points. So I'll pass the mic to her to share her thoughts.
Hello, everyone. I'm so glad that I was doing the teaching points because I learned a lot, but I'm sorry if I missed something. My internet is just so slow. So let's go. So today we started with shortness of breath, and we start thinking, is it lung or heart? And we saw that when we have a fever, we need to favor the lung instead of the heart because it indicates some inflammatory lung disease like a pneumonia. Because you need to remember the lungs, they are open to the world, so they are used to get more infections. But don't forget the heart, because we know that we have endocarditis that can be a devastating diagnosis. So then we move it to the pleuritic chest pain. And the definition is when you have pain with your moving lungs. And first of all, you need to see how pleuritic is the chest pain. So let's try to graduate the pain while breathing. So if you have like an important increase in the pain, it indicates that it's probably pleuritic. So the definition is a pleural irritation by anything that can touch the pleural, like the chest wall, the mediastinal, or the abdomen, and can be caused by, for example, a PE, a pleural effusion, or pneumonia. And then you think, is it the pleural or is it chest wall? So think about the other two P. Is it palpable? Because if it's palpable, you need to think about the chest wall, like muscles or ribs being the cause of the disease. And think about positional, because if it's positional, you need to think about the pericardium. And then you need to think about the 4 diagnoses that you cannot miss, the PE, the pneumothorax, and the aortic dissection, and pericarditis. Then, of course, we went to TB, always a diagnosis, and we thought about that because of the recent travel to an endemic area and the upper lobe location. The incubation period is around 1 month, but can be variable. And you are going to see the exposure to a sick person during a reasonable period of time. So you need a cumulative exposure. And Franco told us that something nice to ask is how many times do you have a meal with the person who is sick together with you to see how much contact time this person has with the sick person. And it's going to depend on your immune status. So if you have, for example, HIV or another immune depression, you are going to think about disseminated TB or other forms of TB. Then we saw that the liver function tests were altered, but we cannot exclude the lung because we have, for example, a typical pneumonia, for example, mycoplasma pneumonia causing altered liver functional tests. Then the question was, we have a liver plus lung syndrome, but what was the first, the liver or the lung? Is it liver plus lung or lung plus liver? We could think, for example, about a pneumonia plus a liver infection causing an abscess. And an example was Chlamydia pneumoniae, a disease that you get from birds and aerosol transmission. Then we saw that we had the liver abscess. And you need to think about a bacterial one or caused by endemic mycosis or in Amoebic, that was the case. And Habi told us a clue that you can have a low red blood cells count because the Amoebic causes cytolytic change, and also echinococcus, of course. Then we also talk about metastatic liver infection. So I always think about this possibility when you have a right lobe dominant infection and you have the 4th or 6th decade of life. And in the end, we saw a little bit about Amoebic disease. So think about that when you have a fever and recent travel. You can use imaging and serology to confirm the diagnosis, the CT or MRI for complications. And that's all for today. Thank you.
Marcella, I hope you're looking at the chat for feedback that everybody's giving you. That was absolutely superb. Such a great distillation of our teaching points today. Really like a pro. Thank you so much. We really hope to see you all. VMR is going strong every single day of the week, but I wanted to let you know that next week is an extra special because we have guests from Saudi Arabia, from Al Faisal University, who are joining us at the exact same time. And so it's a rare delight to get to hang out with colleagues from that part of the world here on VMR. So we're really, really looking forward to it. And of course, everyone is welcome. All right, see you later. Oh, I also forgot to say thank you, Allah, for the reminder. I've been itching for tomorrow. Franco, do you want to tell people a little about what you're doing tomorrow?
So for tomorrow, we are going to have our first session of the clinical reasoning bootcamp. Dr. Ravi, we have an excellent team that we have put together, and we are going to make the comeback to the basics. So tomorrow we are going to have a special VMR regarding problem representation. Hope everyone can join and enjoy it.
Yeah, I couldn't agree more. I'm so excited for it. I will be hiding in the background, learning from these guys, and would just emphasize that it's at the exact same time today, wherever you are. So same time tomorrow, and we really hope to see as many of you there as possible. Problem representation is basically the single most important thing. If you do that well, then it's simply just looking up if you don't know what the answer is. So I really, really appreciate you all starting with, I think, the most fundamental clinical reasoning ask is, what is the problem here? And today the problem was a young man who recently returned from India who has a liver lesion, and arriving at that takes a lot of interpretation, a lot of data. And so I'm excited for the practice tomorrow. All right, I'll see you later.